Hi, I'm Sushant and welcome to this online tutorial by Quest. Discovery of insulin was nothing short of a miracle for management of diabetes. Before insulin, type 1 diabetes mellitus had a universally poor prognosis. But today, we have a variety of oral agents which can help us to manage diabetes, especially type 2 diabetes mellitus. These have changed the prognosis and the way of management of these patients. In this tutorial, let's have a look at these oral hypoglycemic agents which are commonly used in management of type 2 diabetes mellitus. I'm going to focus on what are these class of drugs, what are their common mechanisms, and what would be the usual adverse effects to watch out for. Metformin is usually the first choice in most patients of type 2 diabetes mellitus. It belongs to a class of drugs called biguanides. Primary mechanism of metformin is to decrease the hepatic outflow of glucose, but it also helps by increasing the peripheral utilization of glucose. In other words, it is also helping to reduce insulin resistance. It has advantages. It will cause weight loss, which helps in patients who are obese with type 2 diabetes mellitus. It also improves the lipid profile in a good number of our patients. The only probable adverse effect that we'll encounter is that most of our patients will initially experience some amount of GI adverse effects. But if we gradually increase the dose, that is, if we change the dose every 2 to 4 weeks, most patients will tolerate metformin quite well. One adverse effect that is very popular in the medical literature is lactic acidosis. But honestly, lactic acidosis is not very commonly seen in clinical practices. But patients who have renal disorder, in them lactic acidosis becomes quite common. So we have to avoid using metformin if the creatinine is more than 1.5 or the patient has CKD. We start metformin at a dose of 500 mg per day and we gradually increase the dose up to 1500 mg per day. Up to 1500 mg, we can use metformin as a single agent or as monotherapy. Beyond that dose, we need to consider having an add-on therapy. Now, the commonest add-on therapies are insulin secretagogues. These are drugs which will cause the pancreas to release more amount of insulin. Broadly, there are two categories of insulin secretagogues. First are those which act on the ATP sensitive potassium channels, and second are the ones which use the incretin effect. If we focus on the ATP sensitive potassium channels, these channels are opened by ATP which is generated when glucose enters the cells. Whenever the potassium channels open, they further cause a depolarization of the cell and that leads to release of insulin. Now, when patients of diabetes are having relative insulin deficiency, we can have agents like the sulfonylureas or some other non-sulfonylurea drugs which can act on these ATP sensitive potassium channels. Since the insulin is going to increase, that is going to improve the control of fasting sugar as well as postprandial sugar. We need to remember that these drugs are causing excess insulin secretion from a pancreas which is already under stress. That means they can be best used only in the early years of type 2 diabetes. That is, best results are within the first 5 years of type 2 diabetes mellitus. Also, since we are actually increasing the insulin levels, there is a risk of hypoglycemia with the sulfonylurea group. Such a risk is much lesser with, or in fact almost absent, when we talk about metformin. Now, because of the risk of hypoglycemia, it's important to remember that sulfonylureas should be given just before food. Because of the same insulin, they can also have the adverse effect of weight gain in these patients. Common examples of sulfonylureas used today are glimepiride, glipizide, and glyburide. But there are some non-sulfonylurea compounds which can do the same effect as of sulfonylureas. These are repaglinide or nataglinide. They are better used for patients who have postprandial hyperglycemia. The next class of insulin secretagogues are ones that use the incretin effect. So what is the incretin effect? Whenever glucose reaches the intestines, our intestinal cells release a compound known as a glucagon-like peptide or GLP-1. This GLP-1 helps the pancreas to release more amount of insulin. Therefore, our oral load of glucose causes a better release of insulin than maybe someone getting an intravenous glucose. This difference is known as the incretin effect. The incretin effect is attributed to GLP-1. So an obvious thought was, why not use GLP-1 to manage diabetes? The problem was, GLP-1 that is produced by the human body has a very short half-life. This problem was solved when we started getting GLP-1 agonist. The first of this class was exenatide. It was isolated from the saliva of a reptile known as the Gila monster. Now we have variety of GLP-1 agonists. Apart from exenatide, we have liraglutide. There are new ones like albiglutide, dulaglutide, lixisenatide, and semaglutide. That's quite a lot of names. But all of these agents, they are basically going to have a common set of adverse effects, that is, they are going to slow down the gastric emptying. So all of them would have some amount of GI adverse effects. But the advantage is, since they occur in response to food, the risk of hypoglycemia is much lower. We have also realized that GLP-1, which is a normal compound, is broken down by another enzyme known as dipeptidyl peptidase, or DPP, the isotype 4. So it was thought, why not have inhibitors of DPP-4 which could allow our endogenous, our internal GLP-1 to act better. Such DPP-4 inhibitors are sitagliptin, vildagliptin, and saxagliptin. Now both of these agents, GLP-1 agonists as well as DPP-4 inhibitors, are basically using the same incretin effect and fall in the same category as insulin secretagogues. One difference between the two is GLP-1 agonists are all available in the parenteral form, while DPP-4 inhibitors are in the oral form. And that has made DPP-4 inhibitors much more popular in routine practice than GLP-1 agonists. Next on our list are the alpha glucosidase inhibitors. Now these are drugs which inhibit the breakdown of oligosaccharides. The food that we get, the oligosaccharides, if they are not broken down, that will limit the absorption of glucose. Primarily, the alpha glucosidase inhibitors, that is acarbose, polyblose, or miglitol, they are basically going to prevent the absorption of food and therefore decrease the postprandial sugars. An obvious advantage is a low risk of hypoglycemia, but a disadvantage is that there are going to be GI adverse effects like flatulence. If the starch is going to remain in the stomach, patients can have flatulence as well as diarrhea. Next on our list are a big name, Thiazolidinediones, or TZD. Now these were very popular drugs when they were launched. They act on the PPAR gamma receptors, or peroxisome proliferator activated receptors. These receptors are mainly on the adipocytes, and when the drug acts on these receptors, it basically works by lowering the insulin resistance. Now this is thought to be a wonderful mechanism because that's what my primary pathology is. But the problem is they can have adverse effects. A variety of adverse effects have been recorded in the previous generations of these drugs, but even today, a concern is edema and worsening of heart failure. So I would not use it in patients who have, let's say, the advanced forms of heart failure. Also, they can cause weight gain, which can be troublesome in a lot of obese patients. They have also been reported to worsen macular edema. The agents that we have today are rosiglitazone and pioglitazone. They can be used along with metformin. They can also be used along with sulfonylureas. Now, there is a new class of agent that we are looking at, known as the sodium glucose transporter 2 inhibitor, or SGLT2 inhibitor. What it basically does is it lowers the renal threshold for glucose. That means it allows the glucose to be flushed out in urine without reabsorbing it back. Since we are causing glucoseuria, we are lowering the level of glucose in the blood. This is a very unique mechanism. The drugs in this category are canaglifloxacin, dapagliflozin, and now empagliflozin. They do not really bring down sugars very drastically, but they are a good add-on therapy. But a common concern is if we are going to cause glucoseuria, we are going to make that urine sweet for the bacteria, which means there could be a risk of urinary tract infections. And that's the real trouble with these class of agents today. We have to be careful in using these drugs in patients who have had a past history of UTI. They are less frequently used in women, or as far as possible avoided in women, who, especially the elderly women who might have a risk of UTIs. There are some newer drugs or other drugs which are on the horizons known as amylin agonists. Pramlintide is one of them. We don't really use much of it. There are dopamine agonists like bromocriptine, which are thought to have anti-diabetes effects but not really used in common practice. And there are also bile acid sequestrants which can be used in diabetes, but again, not a common practice. So to summarize, we have seen drugs which are used in diabetes, Metformin remains the first class. It has a lot of advantages. It is an overall relatively safe drug and causes weight loss, which is an added advantage in type 2 diabetes. We spoke a lot about insulin secretagogues, sulfonylureas, non-sulfonylureas, and those which use the incretin effect. GLP-1 agonist and DPP-4 inhibitors both are pretty much doing the same job. We have alpha glucosidase inhibitors which prevent the postprandial hyperglycemia. We have TZDs which have a great mechanism of action but not very much used because of their adverse effects. And the newer agent SGLT2 inhibitors, which apart from an adverse effect of UTI, overall seem to be a good class of agent. If there are any questions on this, feel free to discuss with me on the Quest tab. Thank you and Jai Hind.